Okay, thanks for joining us, everybody. I'm Ali from the Western New South Wales Primary Health Network, and my colleague Meredith is joining me tonight to assist with the webinar. We will get underway. Dr. Budd and Dr. Ali are still coming, so they'll be on a little bit later, but we'll have Dr. Namdi up first. I would like to start this meeting by acknowledging that we work on the traditional lands of many Aboriginal nations across Western New South Wales. I'm in Dubbo, Meredith is in Bathurst, and he's in Bathurst as well. So we're all on Wiradjuri land. I pay respects to all elders, past, present, and future, and acknowledge their continuing connection to land, water, culture, and community. So, our presenters tonight, first up, we have Dr. Namdi, and he is a physiotherapy lecturer at the Charles Sturt University, based at the Orange campus in New South Wales. Sorry, I've got a frog in my throat, which is funny because we're doing respiratory lecture. Just a little bit of housekeeping. So we are recording the session tonight, so you'll be able to have access to this after night. Any questions? If we could put that in the chat box, and we'll address those after each presentation. There'll also be an evaluation at the end, if you wouldn't mind doing that. And I would like to welcome Dr. Namdi.
Thank you, everyone, for having me. My name is Namdim Wemena, and I'm a lecturer at CSU Orange. I teach into the the acute care subject where we do everything cardiorespiratory, so which is good. And this study, as you can see, long-term association between asthma and mental health disorders in Australian males. We're looking at risk factors and impact. So this is part of a collaboration that I've got with, my colleagues from Western Sydney University, and then another from Rural Health Research Institute here at Charles Sturt Orange. And so, yeah, that's about the title. So I'll just skip this one. And looking at the outline for our study presentation today will be on introduction methods, results, discussion on clinical implication, and then the conclusion. So about introduction, I know you'll be so surprised I'm starting my conversation with chronic respiratory diseases, but I promise you I'll, get to the point where we have a pivot down to asthma. So CRDs are non-communicable diseases that affect the lungs and respiratory airways, and we know that COPD and asthma are the most prevalent ones. The common symptoms for these conditions are increased sputum production, dyspnea, persistent cough, wheezing, chest tightness, and fatigue. So in 2019, CRDs were the third most common cause of mortality, accounting for 4 million deaths, with around 454.6 million cases recorded globally. In Australia, they accounted for 29% of mortality in 2022 and 7.2 of total disease burden in 2023, with the prevalence threatening to increase in future years due to continuous exposure to risk factors. So, previous studies have mostly focused on the impact of CRD on a patient's physical health, with limited attention being paid to the mental health. And we know that mental health has become a thing in our recent years. So that's why we decided to, pay more attention in these areas. So mental health disorders such as depression and anxiety are common comorbidities among individuals living with chronic illnesses. And we know CRD is an example or type of chronic illness or chronic condition, as you may put it. The association between these mental health conditions and CRDs have been described to be bidirectional. That means the presence of one makes the other worse, and and it goes vice versa. The Global Initiative for Chronic Obstructive Lung Disease has recommended to actively screen for and co-manage psychological comorbidities in persons living with CRD. And with these, the Lung Foundation Australia has aligned with WHO Global Action Plan for the prevention and control of non-communicable diseases to address the impact of CRDs through health strategies. So when we talk about these strategies, these include promoting pulmonary rehabilitation, where mental health screening is being integrated and support services as well, and also encouraging lifestyle changes such as smoking cessation, regular physical activity, and healthy diets. So We are not saying that these strategies are not being implemented in our Australian health system. We are just only saying that this study, the findings from this study, would hopefully strengthen the rationale for the practices that we are wonderfully doing in our various institutions, if you are currently doing that, which is good, and to add in-depth insights that could inform guidelines and policies in managing patients with these conditions. So the question is, why focus on males? And that was the thing, everyone would ask, what about the females? We love everyone, but it's just that the Australian longitudinal study of male health was started. The 10 to Men study was funded to explore male health, identify key determinants impacting their quality of life, and inform policies aimed at improving the health and well-being of Australian men. So these were the things, that we saw around this 10 to Men study. And then the team came together and we decided to focus on mental health and then CRDs. So when we talk about mental health burden among males is often underestimated and underreported due to complex interplay of factors like culture, stigma, gender norms, lower rates of health-seeking behavior. And I was telling the team, the people who are at the conference that I presented earlier today, I said, it's a thing, culture, stigma. I can relate with it because, I was telling them it was until I moved to Australia around 8 years ago that I actually, knew mental health was a thing because back at home, back in Nigeria, I'm Nigerian and, we don't get to hear around the whole thing. They'll just tell you, tough it up, you're a man, you don't cry and things like that. And I'm like, and I'm here. People are talking about mental health. And I'm like, what is mental health really? So, which is quite interesting. We could see like in a place like Australia that is culturally diverse, it's a thing where culture plays a huge role in this aspect. So with these, we came down with two aims for our study, which were to firstly examine the association between CRDs and mental health disorders. So we're looking at depression, anxiety, and comorbid depression with anxiety among Australian males, using the four waves of the 10 to Men study. Secondly, was to identify the risk factors for depression, anxiety, and comorbid depression with anxiety in Australian males living with CRDs. So we come to methods, but before we get to methods, there's, because I'm a teacher, I love teaching, and one of the analogies I always use to capture my students' attention is just draw up something just to bit of a distraction for them. So I saw this photo around, a barista. This is not me, obviously. Well, I know he looks like me, or rather, I look like him, but hopefully, I could pursue a career in coffee making or being a barista. But the first time I, had coffee when I moved to Australia, I gave I think it was a flat white because I'm not really like a big coffee fan. In back at home we just do like Milo or tea. And then I just said I needed a flat white or something. And he took my order, he started pouring the milk and frothing the milk. And I was like, what is he doing? Like just put the whole thing together and just give it to me. I never knew there are like methods, like stages, how things are being done to make it come out nice. And then it came out like something like this photo that we can see here. And I'm like, oh, why all the design? I'll still drink this and, but then it's just to tell you around methods, how things are being done. So sorry for the digression. I'll bring your minds back to the methods. So let's talk about the methods. So the study was a retrospective study. So we went back to collect the data, just go back in time to collect the data from the 10 to Men study. So they conducted the study across four study waves. So wave one started in 2013 and wave four ended in 2023. So we utilized this, data. So the study involved males aged 10 to 55 at the time of enrollment, and the ethics was also sought and approved, excuse me, from the University of Melbourne Human Ethics Committee. And also the data that we utilized in this study included socio-demographic characteristics, physical and mental health variables, health risk factors, and non-communicable diseases. So there have been a previous publication on the methodology that was used and the sample, the participant recruitment, and this has already been published. So we also had to obtain approval from the data custodian, which was the Australian Institute of Family Studies, for us to use the de-identified data. So when we come to the exposure variables, so we had self-reported COPD or asthma as the exposure variable. So from the study, the participants were asked, has a doctor or other health professional ever told you you had this condition? So ever told you had chronic bronchitis or emphysema or asthma in the last 12 months or in your lifetime? And that was, if they said yes, then, they had it and that was it. So the outcome variable were depression, anxiety, or comorbid depression with anxiety. And then similarly, the question was, has a doctor or other health professional ever told you that you had the condition depression or anxiety in your lifetime or in the last 12 months? And if they said yes to both, then they had a comorbid depression with anxiety. Then if they said just depression, then they had depression. Said just anxiety, just the same thing. So then we looked at confounding variables, which were the social demographic data, health and lifestyle factors, and comorbid conditions. So let's explore the confounding factors in more detail. So we looked at the social demographic data, we looked at the age, the highest educational level, and we had a look at the rurality, we had a look at relationship as well. So whether they were never married or whether they were widowed, divorced, or separated, or married in a de facto relationship. So when we explored the lifestyle and health factors, we looked at smoking status, whether it was never smoked, former smoker, or current smoker. Physical activity levels, whether they met the threshold for physical activity as per the WHO guidelines or they didn't meet the threshold. Body mass index, which are across the four levels that we know. And then the comorbid condition, we check whether they were diagnosed with diabetes, high blood pressure, or sleep issues. And the sleep issues, they were, participants were asked from the 10 to Men study, over the last 2 weeks, how often have you been bothered by any of the following problems? Trouble falling asleep, staying asleep, or sleeping too much. So if they said several days or more, then they were, classified as having sleep issues. So when we look at the statistical analysis for the categorical data for all the social demographic factors, the health and lifestyle factors and comorbid conditions, we use counts and percentages to summarize those information. The chi-square of independence was used to determine examine the prevalence of depression, anxiety, and their comorbidity. Then lastly, a series of generalized estimating equation models were used to examine the association between CRDs and mental health disorder. So we'll have a look at the GE modeling now. So the modeling, we use four models, and the first one was 0 up to 3. So for the first model, which was model 0, so we only adjusted for the confounders, which were the social demographic factors, including the waves. And then in model 1, we now added the health and lifestyle factors. In model 2, we now added the comorbid condition until when we got to model 3, when we added the main predictor, which was the CRD. So the adjusted relative risk and their 95% confidence interval was adopted from obtained from the GE model when we look at the results. And then, we also reported the study following the guidelines of Strobe for reporting retrospective cohort studies. And we use R to do the analysis, R software to do the analysis, and associations were considered statistically significant at P is less than 0.05. And now to the moment we've all been waiting for. You can have a guess what it is because, sometimes it gets really boring. You've been saying too much, like tell us the results, give us what we want to see. So, but before we get into the result, just for me to plead with everyone, please, this study hasn't been sent out for peer review yet. So if we can just abstain or, from taking photos or taking snapshots, that would be well appreciated. Thank you. So looking at the results, I'll use my pointer to really show us like the highlighted areas that are really interesting for us to see. We can see that from the population, we have an increase in age, from what we can see. So from 2014, this was wave one, wave two, three, and four. So from 2014, which was in wave one, we can see that participants who are 50 plus, started increasing. And by the time we got to 2022, they were accounting for 45.5%, as against when they were 15.5% in 2014. So for participants who had university degree was also increasing. So that means, they were going to uni, studying and getting formal education. So we can see from 2014, 26.4 to 44.9 in 2022. So most of the participants were also married as well, in a de facto relationship, and they mostly live like in major cities as well, from what we can see here. So when we're looking at the major cities compared to like the inner regional or outer regional areas. Looking at the lifestyle factors and comorbidities, so we can see that there was a little bit of drop among the current smokers, which was from 27.1% in 2014 to 24.1% in 2022. So those who didn't meet the requirement for physical activity level as per WHO guidelines was really high. You can see that they were accounting for over 80% across the four waves. And those who had high blood pressure as well was increasing. So from 2014, went up from 16.9% to 29.9%. Again, uh, the participants who were in obese category according to the BMI status was also increasing from 19.4 to 30.1. And people who had sleep issues, we can see that nearly half of the participants across the four study waves had sleep issues. So like in 2022, 49%, 51% here, 46, which is close to half as well. So, which is actually really concerning, really. Then lastly, why I highlighted this because we had in mind of analyzing COPD data and asthma, but unfortunately the sample size for COPD was very quite small compared to asthma, which was 2,753 in 2022 who said yes to having asthma or being diagnosed with asthma. So that was why we now focused on asthma. So from now on, all the results I'll be presenting and up to the conclusion will be on asthma and not just CRDs in general. While we look at the prevalence of mental health conditions among Australian males living with asthma, so this is depression, orange is anxiety, and green is depression with anxiety. So we can see that depression remained relatively stable between 2014 and 2016, but then it increased slightly in 2022. And then in 2020, it increased slightly. Then in 2022, it decreased markedly to like 12.8%. For anxiety, it also remained, stable until when we got to 2020, it now plummeted, like it went up, rose up to like 51.3%. So we can see that this was really surprising. And I guess if you're thinking what I'm thinking, we know that there is one thing that we can, attribute this rise to, and that's COVID-19 pandemic. And then in 2022, it starts to come down to like 40.6%. Similarly, we can see that comorbid depression with anxiety was a bit consistent, just stable across the two waves, the first two waves, and then went up in line with the COVID-19, contribution as well. And then in 2022, it starts to drop to what it was in the first two waves. When we look at the association between, oops, sorry. So when we look at the association between asthma and mental health conditions, so if you can remember from what I showed you in the GEE modeling, so this is model 0 where we just adjusted for socio-demographic factors and the waves, and then model 3 where we did add all the other co-founding factors as well as the main predictor. So which is what we are really interested in. So this is actually just trying to show us like in Australian males living with asthma, that they are at higher risk of having, depression. So they are 23% higher risk of having depression. That's what the value is actually trying to show us here. For those males as well, they are at 12% higher risk of, having anxiety compared to those not living with asthma. Lastly, Australian males who are living with asthma are 27% higher risk of having depression with anxiety compared to those who do not have asthma. So we can see that there is actually like a very significant association. And we can see that the confidence intervals, we're showing us that these are significant associations as well. When we have a look at the risk factors, so there are some risk factors that we picked out, keeping in mind that we had COVID-19 as a potential one that must have such things up. And then when we look at the age of the participants, like the younger age, the 20 to 21, we can see that these ones, although they are not quite significant, for depression and comorbid depression with anxiety, but they could suggest a trend. So, but we'll still pick that up as well because we had a look at previous studies that also picked up younger age as a risk factor. Okay, I will be exploring the reasons in the results in the discussion. Sorry. So we had some protective factors, which were having a university degree and being married or in a de facto relationship. So they were a protective factor, meaning that when an individual has got that, they are at a very lower risk of having depression or depression with anxiety if they are living with asthma, as long as they have like a university degree. That's what is being suggestive of, and then married or being in a de facto relationship. So these two factors are more of protective factors. So coming to the lifestyle variables, smoker. So we picked up the analysis picked up current smoker. We can see that they were quite significant across the three mental health conditions. Even former smokers were picked up as well, which is quite interesting because previous studies that we looked at only mostly picked up current smokers. So past or former smokers weren't picked up, which was really an interesting finding in our study. So for high blood pressure, you know, people who had high blood pressure showed that it was also a significant risk factor that was picked up across the three mental health disorders. The same applied to obesity as well. So people who were obese also were picked up as significant risk factor. And people who had sleep issue were picked up. But we can, pay attention to this sleep issue. We can see that our relative risk was 2.4, and this was, for instance, obesity was 1.22. So we can see that, this is almost like twice, having more effect. So it's a stronger risk factor. That's what it's trying to tell us. And when we look at the comorbid depression with anxiety, is even 3.13, which is telling us is actually a stronger risk factor that we need to consider. And, as clinicians, it's something for us to also pay attention to. So bringing this all together now, we just want to know what are the key things that we need to know from this study. So firstly, there is a significant relationship between um, having asthma or living with asthma and being diagnosed with mental health disorders in the future. And also we picked up risk factors of, having a mental health disorder in people in Australian males living with asthma. So we picked up younger age, obesity, high blood pressure, sleep issues, current or past smokers, and COVID-19 as a possible one as well. So we would be exploring the reasons behind this. And firstly, we'll look at the significant association between asthma and mental health disorders. So these association has been attributed to chronic systemic inflammation from the overspill theory and shared factors, particularly from smoking and hypoxemia. So the study by Caulfield in 2021, they talked about this overspill theory, where they talked about chronic airway inflammation that happens in asthma exacerbation or in asthma patient would lead to release of pro-inflammatory cytokines, which leads to systemic inflammation and affects the neurobiological pathways that are very, very necessary in mood regulation. And these could increase risk of developing depression and anxiety. So, we can also look at when we have a look at smoking as another behavioral risk factor. So smoking has also been shown to contribute to airway inflammation, which alters the neurotransmitter systems, affecting mood disorders as well. So I was just like what I said is that our study picked up past or former smokers as a risk factor, where most of the other studies we've looked at were mostly picking up current smokers. So, but it's something for us to pay attention to as clinicians as well. Like if someone is a past smoker, that doesn't mean that the person is not at risk of, having this condition. So it's something that we should pay attention to. So looking at the discussion for the other results, so younger age was picked up as a risk factor for developing depression and comorbid depression with anxiety, and this could be attributed to the younger people's difficulty in understanding the necessity of lifestyle modifications while living with asthma, and also having low mental health literacy could also be another factor to have a look at. We could be leading to this. In people living alone, these factors are such as physical inactivity, social isolation, and lack of emotional support have been identified as risk factors for depression and exacerbation in people living with asthma. So we can see how this, being married or in a de facto relationship is more of a protective factor. So hypertension and obesity as well, quite similar to living alone, can exacerbate physical functional limitation, promote social isolation, and increase psychological distress. Then poor sleep pattern, these have been linked to coexisting obstructive sleep apnea, persistent coughing, nocturnal wheezing, which often intensify asthma exacerbations. And these disturbances impair sleep continuity and efficiency, contributing to chronic sleep deprivation, resulting in emotional dysregulation, increased stress sensitivity, and disruption of neurobiological pathways responsible for mood regulation. Now, what does all of these things, tell us as clinician? What are the clinical implications? Health services for Australian males diagnosed with asthma or may have acute asthma exacerbation should routinely screen for symptoms of depression, anxiety, and their comorbidity. Um, Part of the things that we picked up from our study was that our study was one of the few studies that looked at the comorbid depression and anxiety as one of the mental health disorders, because most of the ones we've seen or we had a look at that were already published, we are either looking at depression or anxiety, but we decided to also have a look at people having a comorbid depression with anxiety. So back to the implication, it could be this, these routine screening could also be done in the hospital or in the community-based pulmonary rehabilitation. And then early identification and treatment interventions could improve overall quality of life and potentially reduce healthcare utilization. So when we're talking about this, we are also calling on all multidisciplinary team. So involving GPs, respiratory physicians, pulmonary rehab team members. So the psychologists, dietitians, nurses, physios, EPs, we all have to, be aligned together to foster a closer therapeutic relationship in the management of patients with CRDs, particularly asthma. The strengths of our study. So part of the thing that we looked at as our strength was having the study being a large population-based sample of Australian males with an 8-year follow-up period. and the use of validated tools such as the PHQ-9 and the GARD-7, which were really validated tools, and they would enhance the reliability of the mental health assessments that were done, also lending credibility to the observed associations. So consideration of a comprehensive set of potential confounders in the analysis. So like we involved, went back to literature, we looked at, all the confounders that, were present in the 10 to men data, and we had to involve them. So there are some confounders that were already listed or published in previous literature, but maybe the 10 to men data never picked them up. So that's one of the things that we tried as much as possible to add all the confounders available, which was good. Then looking at the limitation, um, so there is a reliance on self-reported asthma diagnosis without confirmation from spirometry or radiological imaging or even medical reports review. So that's one of the limitations we picked up, because we know that with spirometry, that would help us to, delineate the asthma severity for this patient, because the severity of asthma has been shown to be a strong predictor of depression in previous studies. So, but that's one of the things we never had available, because they never did spirometry. It was more like self-report. Observational nature of the study hinders any definitive causal inferences. And then lastly, the ethnicity of the participants was not reported, which may limit the generalizability of the findings to all Australian males. And we know that ethnicity is a big thing in terms of, a big factor in determining the lung function of an individual. So, conclusion, there is an increasing prevalence of depression, anxiety, and the comorbidity of both disorders among Australian males living with asthma. There was also a significant long-term association between asthma and elevated risk for mental health disorders, particularly comorbid depression with anxiety among Australian males. And these policies should prioritize identification and support for males at increased risk of having these mental health disorders. And we're looking at males, especially those who are younger, widowed, divorced, or separated, those experiencing sleep disorders or sleep issues, and males living with hypertension, obesity, or they used to be past smokers, or they are current smokers. And these are my references. And thank you for listening. Thank you.
Okay,
Thank
thank you,
you.
Namdi. And thank you for joining us tonight. And feel free to leave. I know you had to go a bit earlier.
Yeah.
We've got Dr. Budhima is online with us now too. Welcome, Dr. Bud, and thank you for joining us. I know you've had a big day with the face-to-face respiratory conference. So Dr. Bud will be talking to us about rare and interesting cases. And he's a respiratory and sleep physician based in Orange. Thank you very much.
Thank you so much for inviting me, Ali and Meredith. It's a pleasure to present here.
Thanks for being here. It's very much appreciated.
So today I'm going to present on just an interesting clinical case that I have in the Central West. My name is Bud Naniakara. I'm a respiratory and sleep physician, and yeah, thank you for having me here. Feel free to interrupt me at any time to ask any questions. Let's keep on going. Oops, there we go. So this case centers around a 26-year-old male. He's of Lebanese descent. He's an ex-smoker and a retired labourer. And he presents with progressive breathlessness on exertion and cough. And this has been going on for 6 months now. Prior to that, he was actually quite well. He didn't have any relevant background history, had no medical comorbidities, didn't take any regular medications. In Lebanon, he was a goat shepherd. And then when he came to Australia, he worked mainly as a labourer, farmer's hand, odd jobs, built a business, and then has since retired. In terms of his exposure history, he kept 2 canaries and enjoys feeding the chickens in his garden. No relevant family history, so no family history of respiratory diseases, and no prior exposure to TB. on review of systems, it was pretty much unremarkable. For example, he didn't have any small joint arthralgia. He didn't have any eye signs, and the relevant eye signs from a respiratory perspective I usually ask is to elicit signs of uveitis, scleritis, episcleritis, all of which can be associated with autoimmune conditions that have primary lung involvement. He didn't have any muscle aches or pains, and certainly there wasn't any prominent symptoms of gastroesophageal reflux disease. To examine, he was in mild respiratory distress when he came to my consult room. Oxygen saturations showed mild hypoxia with oxygen saturations of 92%. He didn't have any connective tissue disease features on note. He had clubbed hands, and he had some fibrotic crepitations bilaterally, as well as an inspiratory squeak. He didn't have any signs of pulmonary hypertension either. So based on this, I guess it might be a little bit difficult to be interactive in this seminar, but well, we'll try it anyway. Does anyone want to think of a type of or group of diseases that this patient may suffer from, just based on the history and examination that I've presented? I'll see if I've got the Fergus's bird fancier's lung, and Alex thinks could be an interstitial lung disease, dust diseases. All excellent thoughts, and I agree. I think the things on history here for me is the progressive nature of the breathlessness and cough. I guess if I'm thinking about airways disease and asthma, they'd have a more variability and episodic nature to the symptoms, and there'd be probably more of a focus on the cough and wheeze and tightness in the chest. Furthermore, his social history, I think, is important here. So he kept 2 canaries, and I always think that birds are the kryptonite of respiratory physicians. Bird fancier's lungs, terrible, and I see it's quite a common antigen that we see in a condition called hypersensitivity pneumonitis, probably one of the most common antigens that are implicated in that condition. He certainly could have a dust disease, absolutely, given his occupational exposures. And the other thing is his examination features. You know, he's hypoxic, so he's obviously got a gas exchange abnormality. And the other features here that are relevant, I think, are the clubbed hands. And in this context, with that history and the further history of fibrotic crepitations bilaterally, does certainly suggest an interstitial lung disease. And also the inspiratory squeak. Now, that inspiratory squeak actually sounds like a bird squeaking inside the chest, and it can suggest a bronchiolitis, so an inflammation of the small airways. And that we commonly see in conditions that affect the small airways, interstitial conditions affecting the small airways, such as hypersensitivity pneumonitis, where the antigen gets trapped in the respiratory bronchioles, and that causes a inflammatory response just outside the bronchioles, causing some kind of constriction. And when the bronchioles open up during inspiration, it actually makes this musical squeak, quite pronounced when you hear it. So any further history examination or any further investigations that you guys would like to order at this juncture? And I think much of the hard work was done to me by the astute general practitioner. Yes, I agree, Alex. I'm just trying to advance the slides. I think I've there we go. That's better. We started off with lung function tests, and here's the spirometry. Let me just get my laser pointer, if it works. Yeah, so this is the spirometry here, and we've got the flow volume loop to the side there, and then we've got the DLCO measurements. So does this support or refute our going theory of an interstitial lung process? How would we interpret this lung function? So the way I look at it, so always have a look at the spirometry first, and use the spirometry in conjunction with the flow volume loop. So the flow volume loop is just hidden. There we go. It's a bit better for me. So in terms of the flow volume loop, you can see the y-axis is flow and the x-axis is volume. And here what happens, the patient generally takes a big breath in from residual volume all the way to total lung capacity. And then they take a forced expiration as hard and fast as they can. And that peak here is your peak expiratory flow, what you'd normally get in a peak flow meter. And then they keep on breathing out, all the way down to residual volume. Now, this peaking of the flow volume loop and this compression, this is quite synonymous in the patient with interstitial lung disease. The peaking of the peaked expiratory flows may suggest conditions of increased elastic recoil, so something such as increased connective tissue in the interstitium, and certainly argues against airway obstruction. In airway obstruction, there is a rapid fall of expiratory flows as the lung volumes get smaller and smaller and smaller. So it's almost like this concave appearance to the expiratory limb. And that occurs as when you expire, the airways are also getting smaller and smaller and smaller. And as the airways get smaller, the resistance to airflow as a pipe reduces, the resistance increases by the fourth power of the radius. So therefore, the flow drops almost exponentially. And it's very pronounced in people with airways disease. And the way on the table of picking that up is when we go to the spirometric ratio, or the FEV1 to FVC. Now that ratio, if it's less than 0.7 by the GOLD criteria, that diagnoses obstructive respiratory disease. And post-bronchodilator, if that ratio is less than 0.7, that in conjunction with the clinical history would be consistent with COPD diagnosis. Here, the ratio is 0.93, so it's certainly not obstructed. And furthermore, if we look at the forced vital capacity, and forced vital capacity is the volume that the patient takes from total lung capacity all the way to residual volume as they force an exhalation all the way out to the most minimum lung volume they can. That volume is the forced vital capacity. And you can see here that's 45%, which is quite low. And the Z score there is minus 3.5. So that's minus 3.45 standard deviations below the population mean. So much less than the lower limit of normal. So quite low. So this suggests to me a restrictive process, again, supporting our clinical assumption. Then we go to diffusion capacity measurements. And the diffusion capacity measurements essentially assess the gas exchange efficacy of the lung. And here we can see it's 52% predicted. So again, this would be in keeping with an interstitial lung process. As you can imagine, increased scar tissue in the lungs will impair gas exchange and therefore reduce diffusion of gases. Okay, so in terms of the physical examination, a lot can be gleaned from doing a top-to-toe examination in these patients. For example, here we can see puffy fingers and almost some ulceration in the distal fingertips. That may be a sign of a connective tissue disease such as a dermatomyositis or something associated with dactylitis, which can also affect the lungs. Here we can almost see like a sclerodactyly-like process with thickening, maybe some calcinosis, something that we may see in scleroderma, the reduced mouth aperture and some telangiectasia with some skin thickening, again in scleroderma, the malar rash that may suggest lupus erythematosus. Now, lupus rarely causes interstitial lung disease. It can at times cause an acute pneumonitis and pulmonary hemorrhage syndrome, but it is more associated with pulmonary hypertension than an ILD process. Sometimes the nail beds get involved, and for the GPs out there that can perform capillaroscopy, if you look at the nail bed, you can see capillary dropout, giant vessels, and all these kind of things that the rheumatologists look out for, which may point towards a connective tissue disease associated ILD. I've never done it myself. I don't know how to do it. There's a heliotrope rash that you see in dermatomyositis, Grotton's papules here. a shawl sign, again, features of a dermatomyositis, alopecia in lupus, and then the vasculitic rash that may be seen in an ANCA vasculitis. So there's a lot of physical signs that you can see if you take the time to do a top-to-toe assessment of the patient. So in terms of the relevant investigations, so the blood test, so because there is a broad differential diagnosis, although we are thinking this could be an exposure-driven process such as hypersensitivity pneumonitis, I think it's important in a patient with ILD to order a broad set of investigations looking at connective tissue disease-related causes. Eosinophil count was 0.2 to 0.8. I highlight that, excuse me. I highlight that because you can get certain eosinophilic-driven lung processes, such as eosinophilic vasculitis, EGPA, or Churg-Strauss, which was previously named, or like a hypereosinophilic syndrome with the eosinophilic infiltration. IgG4 in this patient was elevated, double the upper limit of normal. IgG4 is associated with a number of systemic illnesses, and I don't know what the clinical significance of that was, but certainly response to immunosuppression. The Budgeriggar antibody was elevated, suggesting bird exposure. Now, in and of itself, that's not really that significant. It doesn't give us an idea of pathophysiology, but it does say that this patient has had bird exposure, which we knew from the clinical history. The other autoimmune panel was negative. Quant Gold, Hep B, Hep C, HIV serology was negative. And that's important because in a patient where we may immunosuppress, we want to know these baseline viral panel prior to starting this before immunosuppression, as we might need to pre-start them. If we have a look at the CT scan, so this is a high-resolution CT scan of the chest. And as you can see, there is increased interstitial infiltrate, ground glass, almost consolidative changes with some bronchiectasis involving the lung without a strong apico-basal gradient. There's a lot more, I think, inflammatory changes in this patient than advanced fibrotic changes that we see. And so this led then to a differential of a possible subacute inflammatory ILD with possible organizing pneumonia, which is a pathological pattern of inflammation, NSIP, which is another different pathological pattern of inflammation, or a chronic hypersensitivity pneumonitis, which is non-fibrotic. There were my major differentials for this patient. I thought it was atypical for idiopathic pulmonary fibrosis because it didn't have any of the HRCT features, and there were no clear autoimmune components. So in terms of ILD, there's over 240 causes for them, so it can be quite difficult to tease out. But the way I like to think about ILD is that there's either IPF or idiopathic pulmonary fibrosis, which is a disease entity of itself with a different diagnostic management pathway to all the other ILDs out there. So one of the biggest things we do as respiratory physicians is we always ask the question, in a patient with ILD, interstitial lung disease, is this patient a patient with IPF? And we look for other causes. We try and exclude other causes. And I'd argue in this patient, this is not IPF. Exposure history and the radiology did not fit. But if there isn't any cause, and if we think this could be IPF, we have to have a look at the HRCT pattern. And all these patients, the evidence is that they must be discussed at a multidisciplinary team meeting. And for us here in Central West, we use the RPA MDT, which I used to be a part of, and I still present quite regularly there. And after an MDT discussion, which involves multiple ILD specialists, rheumatologists, pathologists, radiologists, immunologists, we then make a consensus decision of whether or not we need further tissue to elucidate the diagnosis, or we can confidently or semi-confidently make a diagnosis of idiopathic pulmonary fibrosis. Now, there's a lot of other causes of interstitial lung disease. So there's the idiopathic interstitial pneumonias, autoimmune ILDs. So that's very important to have a look at the physical examination there, and then the autoantibody profile, because those two combinations are key in trying to secure the diagnosis. Sometimes we need tissue biopsy diagnosis, such as in vasculitis, to kind of help really make that diagnosis. Exposure-related causes very important. Of course, asbestosis, silicosis. Silicosis is quite common in our region. Medication. So the medications to consider, and something that I see a little bit of here, is nitrofurantoin, very toxic medication to the lungs, and amiodarone is the one. Methotrexate we used to think of as a very nasty medication for the lungs, but probably we've overestimated that. So the majority of us will continue methotrexate in a patient who has ILD, unless we really think it's related. And then we've got ILDs with cysts and various other manifestations, and sarcoidosis all of itself. Now the blue shading here is just to highlight that some of these conditions, even though not primary fibrotic at the start, can behave like a fibrotic lung condition, and IPF being the fibrotic lung condition. So it can behave with IPF like progress. Here are some of the patterns that we see in terms of our ILD. So idiopathic pulmonary fibrosis, so less so of that inflammatory consolidative ground glass changes, more of these lines, this kind of net-like lines, which we call subpleural reticulation and honeycomb cyst formation, with an apico-basal gradient, so more basal predominant fibrosis. NSIP, a lot more ground glass, and you can see this is kind of shaded increased attenuation areas that we see in NSIP. DIP is a smoking-related ILD. Acute interstitial pneumonia behaves like ARDS, and lymphocytic interstitial pneumonia with cysts and ground glass changes, commonly associated with Sjogren's syndrome and MALT lymphomas and the like. The thing with ILD, and especially IPF, is that it has a really dismal survival, and it's actually got markedly worse survival than a lot of cancers, almost equivalent to the 5-year survival of a lung cancer, yet it never gets considered in the same light. I guess we have to see these interstitial lung abnormalities. We have to consider this as a condition because we can manage it. We can prevent progression, and it's really important to recognize this. Most places advocate for a specialized center in terms of management of ILD, and it's no surprise that ILD centers that specialize in this and have specialized programs and multidisciplinary programs, nurse practitioners, pharmacists, radiologists, dietitians, all that specialize in ILD, their outcomes are better. So there's recent evidence that it lowers mortality with specialized care, reduces all-cause hospitalizations. But in the Central West, I guess we've just got to do what we can do, what we do best, and try and treat the patient in the region as best as possible. Most of my patients want nothing to do with going to Sydney to access this type of specialized care. Other things to think about in terms of the management of ILD is the ABCDE approach. So always assess the patient's needs and values. Think about prevention. Think about education. Clinical trials is an important option, and I guess this is probably more relevant in the tertiary center where you have a specialized center. But there are certain, when they come and see us, we do discuss this as an option to see if they would be willing to travel to Sydney, and hopefully in the future we'll be able to offer certain clinical trials at home. There's a real big push in the region to do clinical trials at home, and that may mean that some of our respiratory patients with these advanced conditions may benefit from these trial options. And in the setting of ILD, there are multiple different options in the horizon that have already gotten European Union and FDA approval in America. So it's an exciting time, I think, for us. Comfort care. So we have to establish a treatable traits approach. So these patients do have quite debilitating symptoms, and we have to think about these individually and try and manage them as best as possible. Comorbidities, cardiovascular, lung cancer, emphysema, gastroesophageal reflux disease. Now, for IPF in particular, they have very shared risk factors of being, old male smoker. So they often have similar comorbidities. Sleep disorder breathing, I think, is one, and I think we probably could do better in the region. So a lot of lung diseases, if you have overlap sleep disorder breathing, most lung diseases have markedly worse outcomes. So in the asthma literature, having obstructive sleep apnea is a significant comorbidity, and treatment can improve asthma-related outcomes. COPD-OSA overlap syndrome is associated with a markedly worse mortality. ILD, OSA, is associated with significant nocturnal hypoxemia and development of pulmonary hypertension. So it's certainly a treatable trait and low-hanging fruit that we may be able to look into. We try and treat the lung condition, and then we also quite early on, I think, have to involve our palliative care specialists, especially in idiopathic pulmonary fibrosis. Now, the thing with idiopathic pulmonary fibrosis is that it is itself quite an insidious lung condition. Now, it's the most common ILD that we see, but from the time of diagnosis, it has an average mortality of 3 to 5 years. So really terrible. And there's multiple trajectories. Generally, we think of IPF as having a patient with a genetic predisposition. A familial history of pulmonary fibrosis is a very potent risk factor for developing idiopathic pulmonary fibrosis in the future. In fact, a lot of the genes that are associated are inherited in an autosomal dominant fashion, such as the telomeropathies. They then develop interstitial lung abnormalities, and we are seeing this a lot more, especially now that we're doing a lot more of these scans, particularly in the light of lung cancer screening. And it's important to have a look at this, and important to refer early, I think, because these patients, especially if we get a diagnosis of IPF, we can start them on antifibrotics and improve their mortality and slow their progression rate quite soon. They then come with symptoms, and we make a diagnosis of UIP or IPF. And as their lung progresses, which they do, unfortunately, there is no cure for this condition. It slowly progresses with time. Antifibrotics just decrease the progression rate by 50%, but they do succumb to their illness. And in the right cohort, we may need to consider lung transplantation as well. A acute exacerbation with accelerated fibrosis kind of looks like this: bilateral ground glass changes with accelerated fibrosis, and that's a really terrible event. It causes rapid deterioration in lung function that very rarely recovers back to baseline. I've never seen it recover back to baseline. If it does, it probably wasn't an acute exacerbation of ILD. The median survival for this is 2.2 months. Terrible. Short-term mortality is 50%. And these patients almost universally die if they get put on a ventilator. So in terms of this patient, look, when I saw him, the provisional diagnosis was a subacute inflammatory ILD. It was hypoxic in mild type 1 respiratory failure. So we decided to treat him with immunosuppression regime. And so I admitted him to Orange-based hospital and gave him 1 gram of methylpred over 3 days, and then transitioned him to prednisone and mycophenolate. Sorry, Alex, I didn't realize you asked the question about nitrofurantoin toxicity. So yes, short-term treatment is probably okay. It's just that patients that I see that have been put on for recurrent recurrent urinary tract infections, and that over time, I think there's a cumulative exposure of the toxicity, and it can cause quite an acute ILD. It's generally in an inflammatory ILD rather than a fibrotic ILD. Can be associated with an eosinophilic pneumonitis as well, but it's generally more long-term rather than short-term exposure. So I think in the short term it's probably okay, but long term for recurrent UTIs may not be the best avenue. So we pulsed him, and you can see his forced vital capacity increased from 1.55 to 1.91, and then even despite the pulse, he's over time as he saw me. I mean, he got a bit better, but he kept on. I saw him on multiple occasions. His FVC continued to decline, and he kept on getting breathless and breathless and breathless. We did trial alternates to mycophenolate, a secondary steroid-sparing agent. So we tried. He had mycophenolate issues in terms of GI side effects. We tried azathioprine after confirming that he wasn't a slow metabolizer, and he couldn't tolerate that. So at that time, I decided to add in nintedanib, which is an antifibrotic, and I'll show you the rationale for that. So I'll need to show the CT scan. So try and remember the original CT scan, and we see this one. And I guess if you can see, I wonder if you can appreciate that now there's a lot more of these lace-like structures in the lung. There's a lot more honeycomb kind of cyst formation. Can you see these bronchi? I don't know if you can see my pointer, but there's some traction bronchiectasis there. So I think the reduced forced vital capacity with the traction bronchiectasis indicates increased progressive pulmonary fibrosis, and now we can treat that with antifibrotics. So we started nintedanib on this patient, but unfortunately he had severe and significant weight loss, so we stopped that. Despite this, he had ongoing deterioration, and he had a presentation to OHS with worsening breathlessness, bilateral ground glass infiltrate, so it behaved as a acute exacerbation. And I thought, on balance here, we need to increase the immunosuppression. He couldn't tolerate the antifibrotics, so I repulsed him with methylpred, and I gave him rituximab to shut down his humoral immunity. 1 gram day 0 and day 14 is the protocol that I use. So he stabilized, he discharged. We assessed him for home oxygen, but he didn't qualify, even though his SATs were 90% at rest, and they drop quite significantly when you exert them. That's actually one of the features on examination that you can assess in your practice. If the patient walks with the oximeter and their oxygen saturations plummet, that means generally one of two things. Either they have significant pulmonary vascular disease, or they have they have an interstitial lung disease. We sometimes do see that in advanced emphysema as well. So his PaO2 was 67, so he didn't fulfill the criterion for home oxygen, and his PaCO2 was 34, so mild respiratory alkalosis on an ABG. Difficult ADLs, ongoing fatigue, and then he represented to OHS with right-sided chest pain, tachypnea, low-grade fevers, and a CRP in the 40s with the following CT chest. So here's a picture, and I guess in the interest of time, I think I'm taking a bit of time, sorry. We can see here there is a thick-walled right upper lobe cavity. And the differential diagnosis here, and you can still see the honeycomb cyst formation here, some traction bronchiectasis. Now, the differential diagnosis here, in his case, because of the immunosuppression was infective, could it be bacteria? Could it be Mycobacterium? Now, I wasn't thinking TB because his quantiferon gold test was negative. It could have been like a environmental Mycobacterium, such as Mycobacterium avium. Could it be a fungal infection? Because his immune suppression was shut down, he's at risk of malignancy. He's an ex-smoker. This could have been a malignancy as well. In the lungs, a cavitating lung lesion we see more commonly in squamous cell carcinoma. It could also be a vasculitic process, pulmonary embolus, though the CTPA was negative, septic emboli, or a small vessel anchor vasculitis can give that as well. So for him, we took all the sputum cultures, we sent the bloods. We sent a repeat autoimmune blood test, and 1 month down the line, I get a call from the microbiology registrar, and we can see this is the first test on the September. No acid-fast bacilli seen on microscopy, but then on the 16th of October, the isolate was identified as Mycobacterium tuberculosis complex, so MTB on PCR. So unfortunately, this gentleman got TB, probably as a complication. But what was interesting was that his quantiferon gold was negative. So it didn't meet the criterion for having latent TB. So the only real explanation for that is either that was a false negative, though the sensitivity of a quantiferon gold test is quite high, especially when you're not on immunosuppression at that time when we did the gold test, or in the intervening time between the quant gold being negative and him having this positive test, he had an exposure. And when we took the history from his wife, he had a sister from Lebanon come visit, and the sister may have had a head cold. So I guess that's the only possible exposure history that I can elicit at that time. But unfortunately, he now has a competing issue of TB in the context of heavy immunosuppression for quite an advanced ILD. Because it was quite breathless, we wanted to have a look to see if there's anything else. So we did an echocardiogram, and the echocardiogram does show there is moderate pulmonary hypertension, although the right ventricle and right atrium didn't seem to be decoupled from the afterload of the pulmonary circulation. However, on right heart catheter study done by Stuart Moss, we found that the mean pulmonary arterial pressure was 54. Now, less than 20. 20 is the upper limit of normal for pulmonary pressures. That 20 is 2 standard deviations above the population mean. So even at 20, that the pressures in your pulmonary circulation are high. And the pulmonary circulation is not designed for high pressures. It's a low pressure system because it has to be low, given that the pulmonary circulation is so delicate for its function as a gas exchanger. So it cannot really tolerate high pressures. The cardiac output was quite low, and the pulmonary vascular resistance was very high. This should be less than 2, but it's 15.9 Woods units. So he's had severe pulmonary hypertension. And unfortunately, in a patient with lung disease, which is group 3 disease, pulmonary hypertension secondary to lung disease has the worst prognosis of all our causes of pulmonary hypertension. So he really, really was struggling. So I guess at current, he's a 76-year-old male. He had an initial inflammatory subacute ILD, possible exposure-driven, possible cellular hypersensitivity pneumonitis, and that's what the consensus diagnosis of the MDT was. He developed progressive fibrosis, multiple medication intolerances, who now has class 3 symptoms, class 4 now actually, advanced fibrotic ILD, group 3 pulmonary hypertension, and severe immunosuppression-related complications with MTB. Unfortunately, I just admitted him yesterday, and he's in his terminal phase of life. So he's had another exacerbation. So he's palliated. So that's my talk. I'll stop sharing my screen, and
thank you, Bud. Yes,
I'll open it for questions. Thank you.
Thank you very much.
Pleasure.
Dr. Ali's online with us. Dr. Ali's a staff specialist with respiratory medicine at the Bathurst Base Hospital. Thank you so much for joining us tonight. Dr. Ali, I know you've had a big day as well, so I appreciate your time.
Perfect. Thank you very much. So my name is Ali. I'm one of the staff specialists. I've just started at Bathurst a couple of months ago. And I thought I'd talk to everyone about pleural effusions because it's one of my specialty interests, a subspecialty interest, but also I do want to bring about some changes in how we actually approach and treat pleural effusions at Bathurst Base Hospital. So I thought this would be a good thing to touch upon. So we'll speak briefly about the etiology, a bit about the pathophysiology. I won't go into much details, but I think we'll touch upon the etiology and the causes, the etiology, the pathophysiology, and then I have three interesting cases that I've come across in Bathurst that I thought it would be interesting to share with everyone. I also want to talk a bit about paraneumonic effusions and empyemas and our approaches to them because that's one of the things. It's quite challenging dealing with complicated paraneumonic effusions and empyemas in the first place, and secondly, it is something that I'm finding quite a lot actually in the Bathurst cohort. Like I must have had at least 12 to 14 empyemas just in a couple of months as as a staff specialist. So yeah, without further ado, we'll start. So, pleural effusion essentially is buildup of fluid around the lungs, so in the pleural cavity and outside the lung. You know, a small amount of pleural fluid, like about 5 mils, 10 mils, is normal, and it's necessary to act as a lubricant for the lungs. And however, when the problem arises when these pleural effusions they become larger in size. So there's about 60 recognized causes of pleural effusions, and they range from connective tissue disorders, transudative etiologies such as heart failure, liver failure, kidney failure, all the way to infections, drugs. And pleural effusions occur as a result of either because the fluid formation is too much, or there's a problem or there's some sort of blockage, and the pleural fluid that is being formed, it's not being absorbed back into the lymphatic system and back into the body. Uh, so generally, pleural effusions are classified into transudates and exudates. Transudates are generally bilateral, but this is not a hard and fast rule. However, if we do find effusions which are bilateral, we should be thinking about transudative causes first, and then later on thinking about exudative causes. So cardiac failure, renal failure, liver cirrhosis. So essentially, if one of your major organ fails, that can result in bilateral effusions. And this is often a result of increased hydrostatic pressure or decreased oncotic pressure. I've got a slide again, just briefly touching upon the pathophysiology, showing you guys of why transudates occur. On the other hand, exudates are usually an inflammatory process. So when I think about pleura and when I think about pleural effusions, I consider pleura as its own organ. And I think that's the way we should all be thinking about pleural diseases. And pleura itself is, it's got its own blood supply, it's got its own lymphatic system, and there's a very tightly controlled homeostasis in the body. And if something happens, or even if, say, for example, any type of inflammation that occurs adjacent to the pleura or in the pleura itself, it will eventually result in a pleural effusion. So exudates are usually unilateral, and the causes are broadly infection, malignancy, connective tissue diseases, and drugs. So infections, most of the time we'll see them in the context of bacterial infections. Um, Initially, you have paraneumonic effusions. The paraneumonic effusions, if they're untreated or if the bug is resistant, will eventually turn into complicated paraneumonic effusion, which will then give rise to an empyema. That's usually that is usually the timeline, chronological timeline. Um, Malignancy, obviously, unilateral effusion, if there's a smoking background or if there's some sort of other malignancy, and now the patient comes with a unilateral effusion, we have to rule out malignancy. Connective tissue diseases, predominantly rheumatoid arthritis, or those connective tissue diseases which cause serositis. So SLE in particularly, these will often result in pleural effusions, vasculitis will as well. Hemothorax, so any rib damage to your ribs, and then resulting in bleeding in the pleural cavity. And then drugs, Practolol, methotrexate, bromocriptine, asbestos, benign asbestos effusion as an etiology, mesotheliomas, And a lot of the times I often see pulmonary emboli causing effusions as well. So I don't exactly remember the percentage, but a fair amount, I would say 10 to 20% of PEs actually present with a pleural effusion, and is generally a small exudative blood-stained effusion. We tend not to tap it in the context of PEs because the patients, first of all, anticoagulated, and secondly, there's nothing to gain. There's not much to gain. We know this is secondary to a PE. And then there's the rare causes. Hypothyroidism can often result in pleural effusions. The mechanism is poorly understood. Yellow nail syndrome, a condition where the nails turn extremely yellow. You get pleural effusions and bronchiectasis. And then chylothorax, which is obstruction of the thoracic duct, usually secondary to trauma or surgery. So yeah, just going through a bit about, etiology and pathophysiology. So if you look at the picture on the left side, um, these are transudates occur, excuse me, due to organ and organ failure. So either there's too much fluid in the system, which is actually forcing out the fluid, so increased hydrostatic pressure, or it's an imbalance. There's not enough protein inside the capillaries, and if there's more protein content in the pleural fluid in the pleural region, then the water and all the fluid actually flows and diffuses to where the increased protein content is. So, cardiac failure, cirrhosis, nephrotic syndrome, anything that causes hypoalbuminemia can result in pleural effusions. And generally, the rule of thumb is that transudative effusions, we tend not to intervene unless the patient is hypoxemic or if the patient is really struggling with dyspnea. The treatment of transudative effusions is to treat the underlying disorder and the underlying cause, which can often be difficult because a lot of the times it's end organ damage and end organ failure, which is resulting in the transudative effusions. Exudative effusions. Now, I really like this picture because if you compare both the capillaries on both the sides, you can see that there's increased pore size in an exudative effusion, and what this is displaying is um, inflammation. Whenever there's inflammation, there's inflammatory cytokines which act at the level of the capillaries in order to facilitate a neutrophilic and highly inflammatory chemotactic response because your body is trying to get cells over to the pleura because if the pleura is inflamed, the capillary pore size increases. So all the protein, all the inflammatory cytokines, anti-TNF, um, all the stuff that causes inflammation can easily pass through into the pleural cavity. So the etiology here is direct, inflammation of the pleura results in increase in the capillary size, and as a result, the protein content, when we measure the protein content of the of the pleural exudative pleural effusions, that's why the protein content is high, is because of all the inflammatory cytokines and the inflammatory response that ensues as a result of inflammation of the pleura. So, things like we spoke about, infections, cancer, TB, connective tissue diseases, they can often result in exudative effusions. Right. So, I imagine I don't expect anyone to know who this young man is. I came across him when I was building the slide, really. But I'm sure we've all come across his work at some point in our lives. Um, but it's good to put a name to the face. Uh, this is Dr. Light. He's the inventor of Light's criteria. And obviously, as a respiratory physician, but even as a medic, or even as a medical student, you can't really pass the respiratory portion of the exam if you don't know what Light's criteria is. So it's quite interesting. I found a couple of pictures of him online. Sadly, he's passed away a couple of years ago, but his legacy lives on. And that this is Light's criteria. So again, as we talked about, the capillary permeability and the pore size of the capillaries. So what Dr. Light proved was that if exudates are a direct result of inflammation and increased protein content, what he essentially proved was that there's more protein content in an exudative effusion. So one of the first things that we will end up doing whenever we come across a pleural effusion is we'll tap the effusion. We'll take some of the sample off, and that's just a diagnostic tap, and check to see whether we're dealing with a transudative effusion or exudative effusion. So if the pleural fluid content of the protein content of the pleural fluid is high, then that implies, what it's indirectly telling you that the capillary pore permeability is increased secondary to some sort of inflammation. So we can sort of narrow it down. It doesn't tell you the exact cause of the effusion, but it kind of, broadly differentiates it into a transudative versus an exudative effusion. The other criteria that he proved was the use of LDH. So pleural fluid has more LDH because it has more inflammation again. And then if the pleural fluid LDH is greater than 2/3 of the upper limit of the normal of your lab value, then that if any one of these is positive, that means that we're dealing with an exudative effusion. If none of these criteria is met, then the pleural effusion is classified as transudative. And this is very important. The other thing, I think one of the lesser known things that's quite interesting, well, I find quite interesting, is that the diaphragm is quite a porous structure. There are microscopic and macroscopic holes inside the diaphragm. And this is important because sometimes when we're trying to figure out what the cause is and we're not getting anywhere near the cause, it's a good idea to sometimes scan just below the diaphragm to see what's actually going on. So I distinctly remember a case as a registrar where, we were doing chest drains upon chest drains, and this gentleman we had was just producing a lot of exudative effusion, and we couldn't find the cause. The cytology kept on coming back negative. And then he complained of some abdominal pain. We ended up doing an ultrasound of his tummy, and we found out that he had a splenic abscess. So the splenic abscess actually there was producing a lot of fluid, and it was producing pus, which is translocating through the diaphragm into the pleural cavity. So it can be challenging, but just one thing to remember is that sometimes, the cause is not in the lungs or in the pleura, and it can be anything in the abdomen. Similarly, a lot of the times we'll see ascites translocate and then result in pleural effusions. There's also an entity called urinothorax, and that happens secondary to urine leaking when there's really big hydronephrosis. There's urine leakage, and that urine actually translocates all the way into the pleural cavity, and then the pleural cavity is just fills up with urine. I have seen one case. It's exceedingly rare, and it's challenging to deal with. Right. So, sorry, Hassan. I think I've got the wrong one. Where is it gone again? Yes. Right. Sorry, can you guys see my screen?
Yeah.
Good. So radiographic appearances, I'm sure we're all aware. So in this X-ray, what you can see is a unilateral effusion on the right side. There's a meniscus, a clear meniscus, and the earliest sign of a pleural effusion is actually obliteration of the CP angle. So it's a very sensitive sign. If you cannot see the costophrenic angle, it's very much likely to be an effusion. And then if you see a meniscus on top of it, then you can be quite certain that you're dealing with an effusion. Clinically, when you listen to this patient, there's going to be decreased air entry on the right side, and there's going to be decreased vocal resonance on the same side as well. And coupled with the X-ray appearances, you'll know that you're dealing with a pleural effusion. So I wanted to talk a bit about parapneumonic effusions and empyemas, just because I've been dealing with them quite a lot just recently. So it's estimated that about 20 to 40% of patients that are hospitalized with the pneumonia will have a parapneumonic effusion. The reason that we often do not see parapneumonic effusions on the X-rays is because there needs to be at least 200 mils of fluid present for it to show up on a chest X-ray. to cause obliteration of the CP angle. CTs and ultrasounds are way more sensitive for picking up pleural effusions. They'll even pick up traces of pleural effusions. So because we don't do CT scans and ultrasounds in the majority of patients with pneumonias, I reckon that's the reason that we don't pick up on these paraneumonic effusions. And clinically, it doesn't make any difference because initially, if it's a simple paraneumonic effusion, if you give antibiotics, it goes away. So it's more of a there's no clinical need to diagnose a paraneumonic effusion. They usually become a problem when the fluid when the CRP becomes plateaued and we're not getting patients not getting any better clinically, biochemically. We repeat a chest X-ray, and then we start seeing a lot more fluid on the chest X-ray. So quickly, just talking about the types of paraneumonic effusion, the way it occurs is usually you have a type of just inflammation of the pleura. And if you give antibiotics at that time, it tends to go away. At that time, we label it as a simple paraneumonic effusion. And the pH, when we check the pH of this fluid, it's more than 7.2. So this fluid is usually on an ultrasound is usually about a centimeter in depth. It's free flowing. There's no loculations. And it just usually resolves with antibiotics. There's not a lot of poor outcomes. If this fluid is left, if, say, the bug is resistant to the antibiotics that we're giving, or if the patient is not compliant with the antibiotics or doesn't get antibiotics on time, the body's normal reaction to control any type of infection or inflammation is to wall it off and is to create adhesions. And that's anywhere in the body. It could be in the muscle, it could be in the abdomen. Similarly, this is what happens in the pleural cavity as well. Your body is trying to wall off, so it makes these fibrous adhesions, and I'll show you guys some pictures of how it actually looks like on an ultrasound as well. The fluid becomes thick. There's a lot of protein content. There's a lot of debris. Necrosis is occurring. And because most of the bacteria, apart from Proteus, thrive in an acidic environment, the pH starts falling down as a result of increased metabolic activity. So there's a lot of lactic acid being produced, a lot of carbon dioxide that is produced as a byproduct of all the metabolic activity that is going on in this effusion. And when we measure the pH and it's less than 7, it's usually less than 7.2. And what the data and the research indicates is that it's at this point, if the pH has fallen down below 7.2, antibiotics generally don't cut it. It's quite difficult for antibiotics to penetrate the pleura. And I'll come back to we'll come to the duration of the antibiotic cover that you need for these effusions as well. So generally, if it starts becoming loculated, if you're getting to the point it becomes loculated, patients require chest drainage. And sometimes you can put a drain in, but a lot of the times we can't manage a drain in because it's so heavily loculated. If the effusion is left and untreated, then it turns into frank pus. And if we see pus, we don't need to measure pH. If anything, it'll destroy the ABG machine. So, if we put a needle into the chest and we get pus out, then the patient just gets a chest tube. So there's 3 stages, the exudative stage, the fibrinoepurulent stage, and the organizing stage. I won't go into details, but generally the fibrinoepurulent stage is the stage where there's adhesions being formed, and the organizing stage is where the body and the pleura is trying to wall the infection. It becomes really thick and almost rind-like, and it results in a trapped lung and can cause restrictive respiratory dysfunction as well. That usually happens at the 2 to 3 week period. This is what a heavily loculated effusion looks like. I've had a couple of cases, 2 cases actually, of 2 young gentlemen just very recently. And we got to this stage within 3 days, right? Despite really broad spectrum antibiotics, the pleura just got infected, and their chest X-rays were absolutely horrendous. And then when I did the ultrasound, these were the appearances that we ended up seeing. And it's these, if you can see these little holes and these cystic spaces, that's the area of fluid. And the body, if we do a thoracoscopy on this patient, or if you open this patient's chest up, it's just a mess. It's a hot mess. It's just full of fibrin. It's just full of little loculations and pockets. And with this patient, the only real treatment of choice here is going to be surgery. We can't, if we try and put a chest drain into this cavity, it just bounces back. It doesn't even go in. And this is what a loculated effusion looks like on a CT scan. So you can see little pockets. So with gravity, you would expect the fluid to accumulate at the bottom of the lungs, at the CP angles, right above the diaphragm. But you can see this is, anteriorly, superiorly, there's just fluid collecting everywhere. And what the body is trying to do is it's trying to wall off the infection to try and prevent the spread of infection. And even though the body is trying to prevent overt sepsis, for us it becomes increasingly challenging because a lot of the times these pockets don't communicate with each other. So we tend to find the biggest pocket, put a chest drain in one of the biggest pockets, we'll drain 500 mils, 600 mils, and then it'll just stop working. The drain will stop working. And generally, again, if you get at that point, then you either attempt fibrinolysis through the chest drain using TPA DNAs, or you refer the patient over to surgery. Not one is better than the other. The verdict is, fibrinolysis is, it's only, I would say, come about in the past 10 years or so, so it's a relatively new modality. But so far that the data we have, not one is better than the other. They're pretty much equivalent. It depends on operator confidence and the center. Some centers, so I know RPA is very fond of using fibrinolysis, whereas Nepean, on the other hand, is much more likely to go for surgery for these patients. So bacteriology-wise, the main culprits are strep and staph, pus-forming organisms, Klebsiella, Pseudomonas haemophilus, less commonly Peptostreptococcus. The other thing I often come across is aspiration. So people who are constantly aspirating, they're at risk of developing chronic empyemas. And then if you have a hemothorax, hemothorax, the main risk with hemothorax is once it stops bleeding is obviously, the main risk is if it's bleeding, then is the patient going to die because of excessive bleeding and tensioning secondary to all the blood that's accumulated in the chest cavity. But if the bleeding stops, then the major risk is development of empyema and complicated paraneumonic effusions because blood in the pleural cavity is very likely to become infected and requires chest drainage. Treatment. So if it's a simple paraneumonic effusion, we give antibiotics and most of the times it'll go away. But if it's getting to the complicated stage or if it's turned into an empyema, then chest drainage. The first attempt is we will attempt chest drainage and we'll give a 4 to 6 weeks of antibiotics. I monitor the CRP very carefully and see what the CRP is doing. It's a great indicator of telling us whether there's any residual disease or not. So a lot of the times, we'll start off with a CRP of 300, we'll give antibiotics, put the chest drain in, or say, if it's just a pneumonia with a paraneumonic effusion, I give antibiotics 2 days, 3 days later, the CRP is now 200 and it's just not budging next few days. We repeat the chest X-ray, we often find, there's a complex paraneumonic effusion or there's an empyema, and that then becomes an indication for chest drainage. So if the chest drain and antibiotics are not successful, then we proceed on to either a pulmonary decortication procedure using via VATS or fibrinolysis with TPA DNAs, which we can do locally. So most places, Orange, Dubbo, and now at Bathurst, we will attempt fibrinolysis if we need to. And then the last resort, which used to be done, but my understanding is less so nowadays, is actually rib resection and prolonged chest drainage. It's quite a big undertaking to remove someone's ribs and leave a chest drain in for 30, 60 days. It's only in extreme circumstances nowadays that we'll see this. So complications of pleural empyemas, there's as we discussed, it's restrictive dysfunction. So developing a restrictive disorder, there's so much fibrin, the lungs becoming trapped, the lungs unable to expand, resulting in a restrictive defect, quality of life reduced, recurrent sepsis, extensive pleural fibrosis, bronchopleural fistula, and the development of empyema necessitans. So, um, you know, if there's pus anywhere and it's not treated or it's not drained, it will try and come out of the skin wherever it is, regardless of wherever it is. Like, if you have a collection underneath the skin, which is bacterial and is forming pus and is growing and there's a lot of pressure, it will eventually cause skin necrosis. The skin will burst and there'll be a fistula formation. This is exactly what happens in the lungs as well. And it can be increasingly challenging to deal with if there's a pluricutaneous fistula. Even the surgeons have a hard time dealing with it. It's not an easy thing. I mean, we live in an advent of antibiotics. I see it less and less. I've had a couple of cases, but they were increasingly very difficult to deal with. And this is just a picture showing it what an empyema necessitans looks like. So the top picture, labeled A, is where there's now pus collection underneath the skin. In a couple of days, the skin is going to get necrosed and all the pus will start bursting out. And if you look at the CT scan at the bottom, you can see, so B is the pleural effusion, the empyema, and A is where there's been destruction of the intercostal tissue of the rib, and there's a lot of necrosis, and it's just now lying subdermally almost. So I thought it'd be interesting to just go through a couple of cases I've come across just to delineate the fact that there's so many different causes of pleural effusions, and the treatment varies on the etiology of what the pleural effusion is. So we had an 81-year-old gentleman. He presented with progressive onset shortness of breath for the past few weeks. So kind of a subacute, borderline chronic presentation. He's now unable to walk a few steps or lie down flat. Oxygen saturations were 92% at room air, blood pressure 115/68, heart rate 92, and respiratory rate was 27. When we listened to his chest, there was decreased air entry bilaterally, and there was decreased vocal resonance bilaterally as well, which implied that this gentleman had bilateral pleural effusions clinically. Cardiovascular examination was normal. Abdominal examination was normal as well. So when we did his blood tests, they're pretty much normal. White cell was normal, CRP was normal, so there wasn't really an infective component here or an inflammatory component. These were normal, albumin levels were normal as well. And this was his chest x-ray. So I'll give you guys a couple of seconds to look at it. So on this chest X-ray, there's a lot of increased vascular markings, but the most striking changes are the bilateral effusion. So there's an effusion on the left, a pleural effusion on the left, and there's also a small pleural effusion on the right. And again, you can't really see the CP angle clearly, and there's a little meniscus there. So about 200, 300 mils of fluid on the right side, about 500, 600 mils of fluid, I'd guesstimate, eyeballically on the left side as well. So bilateral effusions, normal inflammatory markers, elderly patient. My first thought here is a transudative effusion. And this was a CT scan. So there's the CT scan just shows that there's the presence of bilateral effusions. There's a larger effusion on the left and a smaller effusion on the right side. So next investigation of choice here, because if we go through the patient's history, the patient was experiencing orthopnea and worsening shortness of breath, particularly on exertion. We ended up doing an echo. We did not tap this effusion at all. We ended up doing an echo. The echo showed that the patient's ejection fraction was less than 40%. And then the patient had a diagnosis of CCF. We ended up diuresing the patient to good response, got the oxygen saturations back up, got the patient reviewed by the cardiologist, got some PTOT, and then got the patient home. So case number two, so this was slightly more interesting. So these were actually two young gentlemen from the same house. They're sharing a house. There were about seven lads that were sharing a house, and they're all working at Jenolan Caves. They seemed to undergo a viral illness. All seven of them caught it, but two of them became quite unwell after a week. Um, so I'll only speak about one of them, but their imaging, their blood tests, everything was exactly the same. So it was quite interesting, and it took us a while to figure out what was going on. So 1 week history of viral symptoms, which then progressed on to chest pain and coughing, fever, cough, rust-colored phlegm, and they started experiencing night sweats. Oxygen saturations were 93% at room air, heart rate 99, blood pressure 165, and respiratory rate of 27. So investigations, very high white cell, 19.6. Using these were normal, and the CRP was through the roof. It was 335. Albumin levels were low at 22. So just, given this history, one would think that, this is definitely an infective process because of the fact that it's happened within a week's time and the inflammatory markers are very, very high. Albumin in this case is most likely an acute inflammatory response, and it acts as an acute phase reactant, just, denoting that there's a systemic illness at play. So this patient went on directly to have a CT scan, didn't have a chest X-ray. So this is his scanogram, and there's not a whole lot going on here. I mean, there's no effusions. There's hardly any effusions I can see. Not no particularly not seeing any consolidations. And this was the CT scan. So this is the initial CT scan, the first CT scan. And on this, you can see on the left side, there's a very small effusion. It's not too big. And there's a cavity right next to it, just laterally on the left side. And there were multiple cavities. So I don't have the scans at multiple levels, but there were multiple cavities throughout the lungs. So we made a diagnosis because it was so acute. We made a diagnosis of cavitatory necrotizing pneumonia, and we started treating with broad spectrum antibiotics at this point. 72 hours later, the patient was not getting any better. There was clinical deterioration. The CRP got stuck at 260, I believe. The patient continued to spike temperature. And this was his chest X-ray, which was really interesting because it just happened within 72 hours. It was so quick. And on this chest X-ray, you can see this tracheal deviation. The trachea is now deviated onto the right side. You can kind of make out a cavity just in the left upper lobe, but what's more striking is the fact that the CP angle is blunted, and you can see almost a mass which seems to be arising from the pleura. So this is a very pathognomonic sign of empyemas, and this is called the split pleura sign or the D sign. And essentially, there's fluid collection in between the parietal pleura and the visceral pleura, and then it just forms this D shape. And pretty much the only thing that will result in this kind of picture is an empyema. Um, so we ended up doing a CT scan at this point, and you can see now that the patient is now developing loculated effusion. So in the first image, the one at the top, you can see there's an effusion right anteriorly around this region. And it's quite loculated. And then right at the bottom of the, somewhere in the middle of the lung, there's a couple more loculated effusions. And you can start seeing that the pleura is becoming thick as well. So this would be the fibrin or purulent stage. And if this was left behind, this will eventually become the exudative stage, and then the pleura will become thick. So the treatment in this case was we ended up doing a pleural tap. The pH of this fluid was 7.1, I believe. So, it was a complicated pneumonic effusion at that time. But it was so heavily loculated. I believe in one of the gentlemen we could manage to drain, the other gentleman we couldn't manage to drain. And because the deterioration was so rapid, we ended up speaking to the thoracic surgeons at RPA, and both of these patients were moved to RPA. And one of them had two large bore chest drains. The other actually recovered maybe without the chest drain, I believe, but he didn't have a lot of fluid buildup, not as much. So the culprit here was Staph aureus. So I did a bronchoscopy. I did an emergency bronchoscopy on this gentleman because pleural fluid, complicated pneumonic effusions will only give you the MCNS, I believe, is only positive in 40 to 50% of the cases. The yield is very low. It goes up by 10% if you put it in culture bottles. But generally, the yield is quite low and poor. We don't culture a bug, even though we're getting frank pus. It's a bit weird. And I ended up doing a bronchoscopy, an urgent bronchoscopy, and we cultured staph, and the patient was treated for staph, and they subsequently made a recovery, both of them. Last case is 92-year-old gentleman, lifelong smoker, presents with sudden onset shortness of breath and chest pain. Slightly low saturations of 92% room air, raised respiratory rate of 31, blood pressure 110 by 72, and a heart rate of 102 per minute. So blood tests all pretty much normal. Albumin levels are normal, CRP is normal, U's and E's are normal, and full blood count is normal as well. And this was his chest X-ray. I'll give you guys a couple of seconds to look at it, and then I'll start explaining what it shows. So again, this is a very characteristic picture, and the only thing that will ever give you this appearance is a hydropneumothorax. So if you have a pneumothorax and a pleural effusion at the same time, then this is what you will get. You can see that the right lung is collapsed. There's a pretty sizable pneumothorax, but there's no meniscus. It's a flat line, it's an air fluid level. So the only time you see an air fluid level in a pleural cavity is when you have a pneumothorax. So this gentleman has a pneumothorax, and he also has a pretty sizable pleural effusion. He has about 1.5 to 2 liters, I estimate, sitting inside his chest. And if you look a bit more closely, just at the right hilum and the right upper lobe, you can see that there's something, it doesn't look right. So there seems to be something going on at that area. So we ended up doing a CT scan for this gentleman. And so this is just the lung, this is the mediastinal window. And you can see that there's a pleural effusion on the right side. But when you move on to the lung window, this is when things get interesting. So just at the right hilum, there's a cavity. And there's something inside that cavity as well. So it seems like there is something growing inside that cavity. And you can obviously see the pneumothorax just anteriorly and a bit laterally as well. So this patient got a chest drain. We removed the fluid because he was quite symptomatic with it. So lifelong smoker, elderly patient, normal blood tests, new pleural effusion. The first thing I was thinking was we have to rule out cancer. So we ended up doing a diagnostic aspiration first. We checked the pH, but because the fluid amount was quite substantial, I ended up draining. Ended up putting a chest drain. We drained the fluid off, and we did a pan scan. And this is quite interesting. This picture actually shows why this patient had a pneumothorax. So if you see the cavity is not whole. There's a very small slit in the cavity. There's a small tear in this cavity. So what's happened is his cytology came back after a couple of days. It showed adenocarcinoma of the lungs. And what's happened here is there was a slow growing adenocarcinoma in his lungs. And then it turned into a cavity. The cavity at some point burst. The cancer spread to the pleura, started producing the pleural effusion, and when the cavity burst, that's when the patient developed the pneumothorax. You can see as a complication of the chest drain, there's a bit of surgical emphysema just in the muscle and the skin as well, and we see that, that's just one of the side effects. As long as it's not too much, we tend to ignore this degree of subcutaneous emphysema. So this was very challenging because this patient now effectively has a bronchopleural fistula, and he's aged, but his performance status was one. He was a high functioning gentleman, and he was quite well. Um, so I spoke to the surgeons at Nepean. I had the cytology. I knew by then he had cancer. So we have a very friendly surgeon in Nepean. He ended up doing a pleurodesis, a VATS pleurodesis, a wake VATS pleurodesis. So just under local sedation and a local anesthetic, he put some talc in. He had a look. I initially thought that maybe if he could remove the tumor and then staple the rest of the lung back together, that would be ideal. But this is M1A disease. So as soon as it spreads to the pleura, it does become incurable. So he was never going to get cured of it. But I thought maybe, just to give him a bit of quality of life. But by the time the surgeon opened the chest up, he said it was too big. It was pretty much unresectable. So he ended up just doing a talc pleurodesis. Um, and things got a bit better, but only for a month. But we're dealing with stage 4 cancer here. He was just admitted a couple of days ago with the same picture, excuse me, same hydroneumothorax. And when I repeated the CT scan, this cavity is now even bigger and is constantly leaking. The chest drain is in, but there's constant bubbling of the chest drain, indicating that there's an ongoing there's an ongoing leak. Um, so we'll see. He has an infection as well. I'm giving some antibiotics. I'm seeing how he progresses. We might think of an endobronchial valve, or we might think of like a permanent kind of chest drain where we attach maybe a very small underwater seal, or possibly not a lot of options and difficult. These bronchopleural fistulas are very difficult to manage, especially if there's no surgical correction there. So learning point, not all pleural effusions require insertion of chest drains. I would argue that most pleural effusions can be managed on an outpatient basis, just with diagnostic and therapeutic thoracentesis. So we have kits very similar to acidic drains, where we can do literally within 15 minutes, we can drain a couple of liters from a patient, take this kit out, repeat the chest x-ray in 2 hours, observe the patient for 2 hours, repeat the chest x-ray, and if the patient's well and there's no complications secondary to our thoracentesis, we can send the patient home. There's a lot of hospitals that run outpatient pleural services, and that is something I'm quite interested in developing at Bathurst. Bilateral pleural effusions, we should not be sticking needles in. There's a wealth of data that indicates that if you put chest drains in transudative effusions, the outcomes are worse, and there's a lot more complications of the chest drains. And also, if you're not treating the underlying cause, if the patient has heart failure or liver failure, they'll continue to make transudative effusion. The transudative effusion the chest drain will continue to produce fluid. You need to treat the underlying cause. It's very important that we check the pH levels of pleural fluid to guide intercostal chest drainage. So just a couple of months ago, our lab stopped checking pH levels of pleural fluid. And that was because we got new machinery, and those new machines weren't calibrated and they weren't licensed. But I had to have a chat with the pathologists and escalate the situation, because we can't really manage pleural effusions without a pH. It's very, very important that we know what the pH is. And then the last thing is that if you have an exudative effusion, it's important to follow it up with imaging. Sometimes, you have an exudative effusion, we put needles in, we don't get an answer, we never get to the bottom of it, we don't know what's caused it. The guidelines state that these patients should undergo a thoracoscopic evaluation, which might not be a possibility. Our nearest thoracoscopy service would be the surgeon in Sydney. There's no medical thoracoscopy service here. It might be something I develop at a later point, because I am trained for medical thoracoscopies, but not in the near horizon. And at the least, these patients should be very closely followed up with at least 3-monthly, 6-monthly x-rays to see whether there's any new developments in the pleural region or in the lungs, because it could be metastatic disease which has resulted in this exudative effusion. So 10% of all exudative effusions which don't have answers end up being cancers. So this is our proposed pleural pathway that we will try and implement in the next couple of months. So if a patient presents to ED, ED will complete investigations, including chest X-ray and a CT with contrast. They will inform the respiratory team. The respiratory team will come and perform a diagnostic ultrasound tap under ultrasound guidance, and we will send off samples for pleural fluid, pH, cytology, LDH protein, and microbiology culture and sensitivity. If there's no indication of chest drain insertion and the effusion is moderate or large, and the patient is hemodynamically stable, we will perform a bedside therapeutic pleural tap. We'll aim to drain 1 to 1.5 liters as much as we safely can. Repeat a chest X-ray in 2 hours and then discharge the patient. The patient will subsequently be seen in the clinic, outpatient respiratory clinic, where we will then decide whether we need to go head down the medical thoracoscopy route or whether we've got the answers and we've got sufficient answers and we know what the reason of the patient's pleural effusion is. And that way we can avoid unnecessary admissions and also unnecessary chest drains. And that's the end. Any questions?
Thanks, Ali. There's no questions in the chat at the moment, and I'm just going to bring up the evaluation while we just wait to see if there's any questions come in.
Oh,
Bud cases were interesting. Sorry.
Sorry. Bud did know who Dr. Light was, so I'm very impressed with Bud.
Oh, yeah. I'll just give everyone a few moments to do the evaluation, but thank you very much for joining us. And
no problem. Thank you very much for having me. No problem.
And thanks, everyone.
Good evening.
Good night.